Histamine, a key player in allergy and inflammation. Histamine is a biogenic amine synthesized from the amino acid histidine. It is primarily stored in mast cells and basophils, and its release is triggered by various stimuli, including allergens, physical injuries, and certain drugs. Histamine exerts its effects through 4 different receptor subtypes: H1, H2, H3, and H4. Each receptor subtype is coupled to different signaling pathways, leading to a variety of physiological responses. H1 receptors. Location: smooth muscle cells of bronchi, blood vessels, and gastrointestinal tract. Endothelial cells. Central nervous system. Effects: bronchoconstriction, vasodilation, increased vascular permeability, itching, pain, and central nervous system stimulation. H2 receptors. Location: parietal cells of the stomach, smooth muscle cells of the gastrointestinal tract, heart, and central nervous system. Effects: increased gastric acid secretion, increased heart rate, and central nervous system stimulation. H3 receptors. Location: presynaptic nerve terminals in the central nervous system and peripheral tissues. Effects: inhibition of histamine release, modulation of neurotransmitter release, and regulation of sleep-wake cycles. H4 receptors. Location: immune cells, including eosinophils, T cells, and dendritic cells. Effects: inflammation, chemotaxis, and cytokine release. Histamine in allergy and inflammation. In allergic reactions, histamine release from mast cells and basophils plays a central role in the development of symptoms. The binding of histamine to H1 receptors on smooth muscle cells leads to bronchoconstriction, increased vascular permeability, and vasodilation, resulting in symptoms such as sneezing, runny nose, itchy eyes, and wheezing. In addition to its role in allergy, histamine also contributes to inflammatory responses. Histamine release can attract inflammatory cells to the site of injury, promote tissue damage, and contribute to chronic inflammatory diseases. Antihistamines. Blocking the effects of histamine. Antihistamines are drugs that block the effects of histamine by competing with histamine for binding to its receptors. They are primarily used to treat allergic conditions such as allergic rhinitis, allergic conjunctivitis, and urticaria. First-generation antihistamines. Mechanism of action: competitive antagonists at H1 receptors. Examples: diphenhydramine, chlorpheniramine, promethazine. Clinical uses: allergic rhinitis, allergic conjunctivitis, urticaria, motion sickness, insomnia. Adverse effects: sedation, dry mouth, blurred vision, urinary retention, constipation, and anticholinergic effects. Second-generation antihistamines. Mechanism of action: selective H1 receptor antagonists with minimal penetration into the central nervous system. Examples: cetirizine, fexofenadine, loratadine. Clinical uses: allergic rhinitis, allergic conjunctivitis, urticaria. Adverse effects: less sedating than first-generation antihistamines, but may cause headache, fatigue, and dry mouth. Third-generation antihistamines. Mechanism of action: active metabolites with prolonged duration of action and minimal sedative effects. Examples: desloratadine, levocetirizine. Clinical uses: allergic rhinitis, allergic conjunctivitis, urticaria. Adverse effects: generally well tolerated, but may cause headache, fatigue, and dry mouth. Other antihistamines. Topical antihistamines, used for localized allergic reactions, such as itching and inflammation of the skin or eyes. Examples include diphenhydramine cream and azolastine eye drops. Intranasal corticosteroids, often used in combination with antihistamines for the treatment of allergic rhinitis. They reduce inflammation in the nasal passages and decrease mucus production. Conclusion: histamine plays a crucial role in allergic and inflammatory responses. Drugs used in gastrointestinal dysfunction, acid-related disorders. 1. Antacids. Mechanism of action: neutralize gastric acid by direct chemical reaction. Examples: aluminum hydroxide, magnesium hydroxide, calcium carbonate. Clinical uses: treatment of heartburn, acid indigestion, and peptic ulcers. Adverse effects: constipation, aluminum-containing antacids; diarrhea, magnesium-containing antacids; and hypercalcemia, calcium-containing antacids. 2. Histamine 2 receptor antagonists, H2As. Mechanism of action: competitively inhibit histamine binding to H2 receptors, reducing gastric acid secretion. Examples: cimetidine, ranitidine, famotidine, nizatidine. Clinical uses: treatment of peptic ulcers, gastroesophageal reflux disease, GERD, and Zollinger-Ellison syndrome. Adverse effects: generally well tolerated, but may cause headache, dizziness, and diarrhea. 3. Proton pump inhibitors, PPIs. Mechanism of action: irreversibly inhibit the hydrogen-potassium ATPase pump, leading to profound and long-lasting inhibition of gastric acid secretion. Examples: omeprazole, lansoprazole, esomeprazole, pantoprazole, rabeprazole. Clinical uses: treatment of peptic ulcers, GERD, Zollinger-Ellison syndrome, and erosive esophagitis. Adverse effects: headache, diarrhea, and increased risk of infections, e.g. Clostridium difficile. Long-term use may be associated with increased risk of fractures and hypomagnesemia. Gastrointestinal motility disorders. 1. Prokinetic agents. Mechanism of action: increase gastrointestinal motility by stimulating acetylcholine release or blocking dopamine receptors. Examples: metoclopramide, domperidone. Clinical uses: treatment of gastroparesis, delayed gastric emptying, and functional dyspepsia. Adverse effects: extrapyramidal side effects, e.g. dystonia, akathisia, Parkinsonism, with metoclopramide. 2. Antidiarrheal agents. Adsorbents bind to toxins and bacteria, reducing their absorption. Examples: activated charcoal, bismuth subsalicylate. Anticholinergics decrease intestinal motility by blocking muscarinic receptors. Examples: loperamide, diphenoxylate. Opioid agonists slow intestinal transit time by activating opioid receptors. Examples: loperamide, diphenoxylate. Inflammatory bowel disease, IBD. 1. 5-amino-salicylic acid, 5-ASA, derivatives. Mechanism of action: reduce inflammation by inhibiting prostaglandin synthesis and other inflammatory mediators. Examples: sulfasalazine, mesalamine, olsalazine. Clinical uses: treatment of ulcerative colitis and Crohn's disease. Adverse effects: nausea, vomiting, diarrhea, and headache. Sulfasalazine may cause allergic reactions and hemolytic anemia. 2. Corticosteroids. Mechanism of action: suppress the immune system and reduce inflammation. Examples: prednisone, budesonide. Clinical uses: treatment of acute exacerbations of IBD. Adverse effects: hyperglycemia, osteoporosis, fluid retention, and immunosuppression. 3. Immunomodulators. Mechanism of action: modulate the immune system to reduce inflammation. Examples: azathioprine, 6-mercaptopurine, infliximab, adalimumab. Clinical uses: treatment of moderate to severe IBD. Adverse effects: bone marrow suppression, infections, and infusion reactions. Irritable bowel syndrome, IBS. 1. Antispasmodics. Mechanism of action: reduce smooth muscle spasms in the gastrointestinal tract. Examples: hyoscyamine, dicyclomine. Clinical uses: treatment of abdominal pain and cramping associated with IBS. Adverse effects: dry mouth, blurred vision, urinary retention, and constipation. 2. Selective serotonin, reuptake inhibitors, SSRIs. Mechanism of action: increase serotonin levels in the brain and gut, modulating gastrointestinal motility and sensation. Examples: fluoxetine, paroxetine, sertraline. Clinical uses: treatment of diarrhea-predominant IBS. Adverse effects: sexual dysfunction, insomnia, and weight gain. Drugs acting on serotonergic systems. Serotonin, 5-hydroxytryptamine, 5-HT, is a neurotransmitter involved in a wide range of physiological and psychological processes, including mood, sleep, appetite, and pain perception. Drugs that act on serotonergic systems can be broadly classified into 3 categories. 1. Serotonin, reuptake inhibitors, SSRIs. SSRIs selectively inhibit the reuptake of serotonin from the synaptic cleft, increasing its availability in the synapse. This leads to enhanced serotonergic neurotransmission. Clinical uses: major depressive disorder, obsessive-compulsive disorder, OCD, panic disorder, social anxiety disorder, post-traumatic stress disorder, PTSD, premenstrual dysphoric disorder, PMDD, fibromyalgia, common SSRIs, fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, escitalopram. Adverse effects: sexual dysfunction, gastrointestinal disturbances, nausea, diarrhea, constipation. Insomnia or sedation, headache, anxiety, weight gain or loss, hyponatremia. 2. Serotonin norepinephrine, reuptake inhibitors, SNRIs. SNRIs inhibit the reuptake of both serotonin and norepinephrine, leading to increased levels of both neurotransmitters in the synapse. Clinical uses: major depressive disorder, generalized anxiety disorder, GAD, panic disorder, social anxiety disorder, fibromyalgia, common SNRIs. Venlafaxine, duloxetine, desvenlafaxine, levomilnacipran. Adverse effects: similar to SSRIs, including sexual dysfunction, gastrointestinal disturbances, and insomnia. Increased blood pressure, sweating, dry mouth, nausea, dizziness. 3. Serotonin, norepinephrine, disinhibitory drugs, SNDIs. SNDIs enhance the release of both serotonin and norepinephrine from presynaptic neurons. Clinical uses: major depressive disorder, common SNDI, vilazodone. Adverse effects: nausea, diarrhea, headache, dizziness, insomnia. 4. Serotonin modulators. Serotonin modulators affect serotonergic neurotransmission through various mechanisms, including partial agonism, antagonism, and inverse agonism at specific serotonin receptors. Clinical uses: major depressive disorder, anxiety disorders, migraine headache, common serotonin modulators, buspirone, partial 5-HT1A agonist, trazodone, serotonin antagonist and reuptake inhibitor, nefazodone, serotonin antagonist and reuptake inhibitor, vortioxetine, multiple mechanisms of action. Adverse effects: sedation, dizziness, headache, nausea, dry mouth, weight gain. 5. Tricyclic antidepressants, TCAs. TCAs inhibit the reuptake of both serotonin and norepinephrine, but they also have additional effects on other neurotransmitter systems, such as histamine and acetylcholine. Clinical uses: major depressive disorder, anxiety disorders, chronic pain, neuropathic pain, common TCAs, amitriptyline, nortriptyline, imipramine, dizipramine. Adverse effects: anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention. Sedation, cardiovascular effects, orthostatic hypotension, tachycardia, weight gain. It is important to note that the choice of medication for a specific patient depends on various factors, including the diagnosis, severity of symptoms, and individual patient characteristics. It is crucial to consult with a healthcare professional for appropriate diagnosis and treatment. Eicosanoids, a class of lipid mediators. Eicosanoids are a class of lipid mediators derived from arachidonic acid, a 20-carbon polyunsaturated fatty acid. They play a crucial role in various physiological processes, including inflammation, pain, fever, and blood clotting. Biosynthesis of eicosanoids. Eicosanoids are synthesized through two major pathways: cyclooxygenase, COX, pathway, COX-1, constitutively expressed in most tissues involved in maintaining normal physiological functions. COX-2, induced by inflammatory stimuli involved in the production of inflammatory mediators. The COX pathway leads to the formation of prostaglandins, PGs, and thromboxanes, TXAs. Lipoxygenase, LOX, pathway. 5-LOX, 12-LOX, and 15-LOX are the major isoforms. The LOX pathway leads to the formation of leukotrienes, LTs, and lipoxins, eicosanoids, and inflammation. Prostaglandins, PGE2, vasodilation, pain, fever. PGI2, vasodilation, inhibition of platelet aggregation. TXA2, vasoconstriction, platelet aggregation. Leukotrienes, LTC4, LTD4, LTE4, bronchoconstriction, vasoconstriction, increased vascular permeability. LTB4, neutrophil chemotaxis drugs targeting eicosanoid pathways. 1. Nonsteroidal anti-inflammatory drugs, NSAIDs. NSAIDs inhibit the COX enzymes, thereby reducing the production of prostaglandins. Non-selective NSAIDs inhibit both COX-1 and COX-2. Examples: aspirin, ibuprofen, naproxen. Clinical uses: pain, fever, inflammation, and platelet inhibition. Aspirin. Adverse effects: gastrointestinal ulcers, renal impairment, cardiovascular risk, especially with COX-2 selective NSAIDs. COX-2 selective NSAIDs, coaxiBs, inhibit primarily COX-2. Examples: celecoxib, rofecoxib, withdrawn. Clinical uses: pain, inflammation, and osteoarthritis. Adverse effects: increased risk of cardiovascular events, UEG, myocardial infarction, stroke. 2. Corticosteroids. Corticosteroids inhibit the transcription of genes encoding inflammatory mediators, including COX-2 and phospholipase A2. Clinical uses: severe inflammation, autoimmune diseases, allergic conditions. Adverse effects: hyperglycemia, osteoporosis, fluid retention, immunosuppression. 3. Leukotriene receptor antagonists. These drugs block the effects of leukotrienes, particularly LTC4, LTD4, and LTE4. Examples: montelukast, zafarlukast. Clinical uses: asthma, allergic rhinitis. 4. 5. Lipoxygenase inhibitors. These drugs inhibit 5-LOX, reducing the production of leukotrienes. Example: Xileuton. Clinical uses: asthma. Therapeutic implications. By understanding the role of eicosanoids in various physiological processes, we can develop targeted therapies for a wide range of diseases. For example, NSAIDs are widely used for pain relief and inflammation, while leukotriene receptor antagonists are effective in treating asthma. However, it is important to consider the potential adverse effects of these drugs, especially with long-term use. Drugs used in the treatment of rheumatoid arthritis. Rheumatoid arthritis, RA, is a chronic autoimmune disease characterized by inflammation of the joints. Drug therapy for RA aims to alleviate pain, reduce inflammation, and slow disease progression. Non-pharmacological therapies. Physical therapy to maintain joint function and mobility. Occupational therapy to adapt daily activities to minimize joint stress. Weight management to reduce stress on weight-bearing joints. Exercise to improve joint function and overall physical health. Pharmacological therapies, nonsteroidal anti-inflammatory drugs, NSAIDs. Mechanism of action: inhibit cyclooxygenase, COX, enzymes, reducing prostaglandin production. Clinical use: alleviate pain and inflammation. Examples: ibuprofen, naproxen, celecoxib. Adverse effects: gastrointestinal ulcers, renal impairment, cardiovascular risk. 2. Corticosteroids. Mechanism of action: suppress the immune system and reduce inflammation. Clinical use: rapid relief of severe inflammation. Examples: prednisone, prednisolone. Adverse effects: hyperglycemia, osteoporosis, fluid retention, immunosuppression. 3. Disease-modifying anti-rheumatic drugs, DMARDs. A. Conventional synthetic DMARDs, cis-DMARDs. Methotrexate. Mechanism of action: inhibits DNA synthesis and immune cell proliferation. Clinical use: first-line therapy for RA. Adverse effects: liver toxicity, bone marrow suppression, gastrointestinal upset. Sulfasalazine. Mechanism of action: anti-inflammatory and immunosuppressive effects. Clinical use: mild to moderate RA, especially in patients with inflammatory bowel disease. Adverse effects: gastrointestinal upset, rash, headache. Hydroxychloroquine. Mechanism of action: uncertain, may interfere with immune cell function. Clinical use: mild to moderate RA, often used in combination with methotrexate. Adverse effects: retinal toxicity, gastrointestinal upset. Leflunomide. Mechanism of action: inhibits pyrimidine synthesis, affecting immune cell proliferation. Clinical use: moderate to severe RA. Adverse effects: liver toxicity, diarrhea, alopecia. B. Biologic DMARDs, BDMARDs. Tumor necrosis factor, TNF. Inhibitors. Examples: infliximab, adalimumab, etanercept. Mechanism of action: neutralize TNF-alpha, a key inflammatory cytokine. Clinical use: moderate to severe RA, especially when CS-DMARDs are ineffective. Adverse effects: increased risk of infections, heart failure. Interleukin-6, IL-6, inhibitors. Examples: tocilizumab, saralimumab. Mechanism of action: block IL-6, a pro-inflammatory cytokine. Clinical use: moderate to severe RA. Adverse effects: increased risk of infections, lipid abnormalities. Janus kinase, JAK, inhibitors. Examples: tofacitinib, upadacitinib. Mechanism of action: inhibit JAK enzymes, which are involved in cytokine signaling. Clinical use: moderate to severe RA. Adverse effects: increased risk of infections, blood clots, and cardiovascular events. Combination therapy. Often, a combination of DMARDs is used to achieve optimal disease control. The specific combination and dosing regimen will depend on the individual patient's needs and response to therapy. Monitoring and management: regular monitoring of disease activity, laboratory tests, and potential adverse effects is crucial for optimizing therapy and minimizing side effects. Drugs used in the treatment of gout. Gout is a type of inflammatory arthritis caused by the buildup of uric acid crystals in the joints. The treatment of gout involves acute management of gout flares and long-term management to prevent future attacks and reduce the risk of complications. Acute gout flare treatment. 1. Non-steroidal anti-inflammatory drugs, NSAIDs. Mechanism of action: inhibit cyclooxygenase, COX enzymes, reducing prostaglandin production. Clinical use: rapid relief of pain and inflammation. Examples: ibuprofen, naproxen. Adverse effects: gastrointestinal ulcers, renal impairment, cardiovascular risk. 2. Colchicine. Mechanism of action: inhibits microtubule polymerization, impairing neutrophil function and reducing inflammation. Clinical use: effective in reducing the severity and duration of acute gout attacks. Adverse effects: gastrointestinal upset, diarrhea, nausea, vomiting, muscle weakness, and neurotoxicity. 3. Corticosteroids. Mechanism of action: suppress the immune system and reduce inflammation. Clinical use: rapid relief of severe gout flares, especially in patients who cannot tolerate NSAIDs or colchicine. Examples: prednisone, prednisolone. Adverse effects: hyperglycemia, osteoporosis, fluid retention, immunosuppression. Long-term management of gout. 1. Uricosuric drugs. Mechanism of action: increase uric acid excretion by the kidneys. Clinical use: lower serum uric acid levels and prevent future gout attacks. Examples: probenecid, sulfampirazone, lisinorid. Adverse effects: kidney stones, hypersensitivity reactions, gastrointestinal upset. 2. Xanthine oxidase inhibitors. Mechanism of action: inhibit xanthine oxidase, the enzyme that converts hypoxanthine to xanthine and xanthine to uric acid. Clinical use: lower serum uric acid levels and prevent future gout attacks. Examples: allopurinol febuxostat. Adverse effects: skin rash, gastrointestinal upset, liver dysfunction. 3. Uricolitic drugs. Mechanism of action: convert uric acid to more soluble metabolites. Clinical use: lower serum uric acid levels and prevent future gout attacks. Example: pegloticase. Adverse effects: infusion reactions, hypersensitivity reactions, lifestyle modifications, dietary changes. Limit intake of purine-rich foods, organ meats, seafood, red meat, alcohol. Weight management: maintain a healthy weight to reduce uric acid production. Hydration: drink plenty of fluids to help flush uric acid from the body. The choice of treatment for gout depends on the severity of the disease, the frequency of attacks, and the patient's individual needs. It is important to work with a healthcare provider to develop a personalized treatment plan. Glucocorticoids, powerful anti-inflammatory agents. Glucocorticoids are a class of steroid hormones produced by the adrenal cortex. They play a crucial role in various physiological processes, including stress response, immune function, and metabolism. Synthetic glucocorticoids are widely used in medicine for their potent anti-inflammatory and immunosuppressive effects. Mechanism of action: glucocorticoids exert their effects by binding to glucocorticoid receptors, which are present in almost all cells of the body. Upon binding, the glucocorticoid receptor complex translocates to the nucleus, where it binds to DNA and regulates the transcription of various genes involved in inflammation and immune response. Anti-inflammatory effects: glucocorticoids inhibit the production of inflammatory mediators, such as cytokines, prostaglandins, and leukotrienes. They also stabilize cell membranes and inhibit the migration of inflammatory cells. Immunosuppressive effects: glucocorticoids suppress both innate and adaptive immune responses. They inhibit the proliferation and activation of T lymphocytes, B lymphocytes, and macrophages. Therapeutic uses of glucocorticoids. Glucocorticoids are used to treat a wide range of inflammatory and autoimmune diseases, including allergic disorders, allergic rhinitis, asthma, allergic dermatitis, autoimmune diseases, rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, organ transplantation, prevention of rejection, respiratory diseases, chronic obstructive pulmonary disease, COPD, acute respiratory distress syndrome, ARDS, hematological disorders, autoimmune hemolytic anemia, thrombocytopenic purpura, dermatological disorders, psoriasis, eczema, contact dermatitis, ophthalmic disorders, uveitis, allergic conjunctivitis, routes of administration. Glucocorticoids can be administered through various routes, including oral, for systemic effects, intravenous, for rapid systemic effects, intramuscular, for sustained systemic effects, inhalation, for localized effects in the lungs, topical, for localized effects on the skin or mucous membranes. Adverse effects of glucocorticoids. Prolonged or high-dose glucocorticoid therapy can lead to a variety of adverse effects, including endocrine disorders, adrenal suppression, Cushing's syndrome, metabolic disorders, hyperglycemia, weight gain, osteoporosis, gastrointestinal disorders, peptic ulcer disease, pancreatitis, neuropsychiatric disorders, mood disturbances, insomnia, psychosis, musculoskeletal disorders, muscle weakness, osteoporosis, ocular disorders, cataract formation, glaucoma. Important considerations. Tapering. When discontinuing long-term glucocorticoid therapy, it is important to taper the dose gradually to avoid adrenal insufficiency. Monitoring. Regular monitoring of blood glucose, blood pressure, and bone mineral density is essential. Patient education. Patients should be educated about the potential side effects of glucocorticoid therapy and the importance of adhering to the prescribed treatment plan. By understanding the mechanisms of action and therapeutic uses of glucocorticoids, healthcare providers can effectively utilize these powerful drugs to treat a wide range of inflammatory and autoimmune diseases while minimizing adverse effects. Drugs used in the treatment of asthma. Asthma is a chronic inflammatory airway disease characterized by reversible airway obstruction, bronchial hyperresponsiveness, and airway inflammation. Drug therapy for asthma aims to relieve symptoms, prevent exacerbations, and improve lung function. Quick relief medications. These medications provide rapid relief of acute asthma symptoms. 1. Short-acting V2 adrenergic agonists, SABAs. Mechanism of action: relax bronchial smooth muscle by stimulating V2 adrenergic receptors. Clinical use: rapid relief of acute bronchoconstriction. Examples: albuterol, levobuterol. Adverse effects: tachycardia, tremor, anxiety. 2. Anticholinergic drugs. Mechanism of action: block muscarinic receptors, leading to relaxation of bronchial smooth muscle. Clinical use: rapid relief of bronchoconstriction, often used in combination with SABAs. Examples: ipratropium bromide. Adverse effects: dry mouth, blurred vision, long-term control medications. These medications reduce inflammation and airway hyperresponsiveness, preventing asthma attacks. 1. Inhaled corticosteroids, ICS. Mechanism of action: suppress inflammation by inhibiting the release of inflammatory mediators. Clinical use: long-term control of asthma symptoms. Examples: fluticasone propionate, budesonide, beclomethasone dipropionate. Adverse effects: oral thrush, hoarseness. 2. Long-acting V2 adrenergic agonists, LABAs. Mechanism of action: similar to SABAs but with a longer duration of action. Clinical use: long-term control of asthma symptoms, often used in combination with ICS. Examples: salmeterol, formoterol. Adverse effects: similar to SABAs, but with a lower risk of side effects. 3. Leukotriene modifiers. Mechanism of action: block leukotriene receptors or inhibit leukotriene synthesis. Clinical use: for patients with persistent asthma, especially those with exercise-induced bronchoconstriction or aspirin sensitivity. Examples: montelukast, zafirlukast. Adverse effects: headache, gastrointestinal upset. 4. Theophylline. Mechanism of action: relaxes bronchial smooth muscle and inhibits inflammation. Clinical use: less commonly used but can be effective in certain patients. Adverse effects: cardiac arrhythmias, seizures, gastrointestinal upset. 5. Omalizumab. Mechanism of action: monoclonal antibody that binds to IgE, reducing its ability to trigger allergic reactions. Clinical use: severe allergic asthma. Adverse effects: injection site reactions, headache, combination. Therapy for optimal asthma control: combination therapy is often used. Common combinations include ICS, pulse. LABA reduces inflammation and bronchoconstriction. ICS plus long-acting muscarinic antagonist, LAMA, reduces inflammation and bronchoconstriction, especially in patients with significant airway obstruction. The choice of therapy depends on the severity of asthma, the frequency and severity of symptoms, and the patient's individual needs. Regular monitoring and adjustment of therapy are essential to optimize asthma control and minimize adverse effects. Drugs used in the treatment of inflammatory disorders. Inflammatory disorders are a diverse group of conditions characterized by inflammation, which is the body's response to injury or infection. While inflammation is a normal physiological process, chronic or excessive inflammation can lead to tissue damage and disease. Non-steroidal anti-inflammatory drugs, NSAIDs, are a class of drugs that inhibit the production of prostaglandins, which are involved in pain, fever, and inflammation. Non-selective NSAIDs inhibit both COX-1 and COX-2 enzymes. Examples: aspirin, ibuprofen, naproxen. Clinical use: pain, fever, inflammation, and platelet inhibition, aspirin. Adverse effects: gastrointestinal ulcers, renal impairment, cardiovascular risk, especially with COX-2 selective NSAIDs. COX-2 selective NSAIDs, COX-IBs, inhibit primarily COX-2. Examples: celecoxib, rofecoxib, withdrawn. Clinical use: pain, inflammation, and osteoarthritis. Adverse effects: increased risk of cardiovascular events, e.g., myocardial infarction, stroke. Corticosteroids. Corticosteroids are potent anti-inflammatory drugs that suppress the immune system. They are used to treat a wide range of inflammatory disorders. Mechanism of action: inhibit the transcription of genes encoding inflammatory mediators, including COX-2 and phospholipase A2. Clinical uses: severe inflammation, autoimmune diseases, allergic conditions. Examples: prednisone, budesonide. Adverse effects: hyperglycemia, osteoporosis, fluid retention, immunosuppression. Disease-modifying anti-rheumatic drugs, DMARDs. DMARDs are used to slow the progression of autoimmune diseases like rheumatoid arthritis. Conventional synthetic DMARDs, CSDMARDs. Methotrexate inhibits DNA synthesis and immune cell proliferation. Sulfasalazine, anti-inflammatory and immunosuppressive effects. Hydroxychloroquine interferes with immune cell function. Leflunomide inhibits pyrimidine synthesis, affecting immune cell proliferation. Biologic DMARDs, BDMARDs. Tumor necrosis factor, TNF. Inhibitors neutralize TNF-alpha, a key inflammatory cytokine. Interleukin-6, IL-6. Inhibitors block IL-6, a pro-inflammatory cytokine. Janus kinase, JAK. Inhibitors inhibit JAK enzymes, which are involved in cytokine signaling. Other anti-inflammatory drugs. Leukotriene. Modifiers block the effects of leukotrienes, reducing inflammation. 5. Lipoxygenase. Inhibitors inhibit the synthesis of leukotrienes. Immunosuppressants suppress the immune system, such as cyclosporin and tacrolimus. Considerations for drug therapy. Individualized treatment. The choice of drug therapy depends on the specific inflammatory disorder, its severity, and the patient's individual needs. Potential side effects. It is important to weigh the benefits and risks of each drug and to monitor patients closely for adverse effects. Combination therapy. Often, a combination of drugs is used to achieve optimal therapeutic effects. Non-pharmacological interventions, lifestyle modifications such as diet and exercise, can also play a role in managing inflammatory disorders. By understanding the mechanisms of action and therapeutic uses of these drugs, healthcare providers can effectively treat a wide range of inflammatory disorders and improve patient outcomes.